Thank you very much. So, for the sake of time, because immediately after this session, we have to move on to closing ceremony. So, I want to keep in time. So, my subject is inflammatory myopathy. This is my disclosures. I think first of all, I think all of you have learned that there is two types of myositis. One is polymyositis. The other one is dermatomyositis. What is the difference? Whether the patient has skin rash or not. That is the only, difference. That's what we learned, actually, what I learned long time ago. And so then that is the classical clinical classification. But nowadays, it's going to be changed. Actually, it has been changed already. And this is, as I will mention in my talk, this is because now we know that the mechanism is different. It's not that simple. So previously, we just used steroid. So whatever the diagnosis, anyway, you will use steroids. So it doesn't matter whether you call it dermatomyositis, polymyositis, it doesn't matter. But now it matters, okay? And then there are 4 well-established categories, subtypes: immune-mediated necrotizing myopathy, dermatomyositis, antisynthetase syndrome, and inclusion body myositis. Now there's no polymyositis anymore. And there are less well-established categories. We are not sure whether they are independent one or not independent one. We're not sure. So I will talk about those 4 subtypes today. So first, immune-mediated necrotizing myopathy. So clinically, this is the classical polymyositis. Patients usually have proximal muscle weakness, subacute, progressive, and CK is high, 1,000 usually. And MRI, you can see diffuse edema like this. And typically non-skin rash. And there are 2 specific autoantibodies so far identified. One is SRP and the other one is HMGCR antibodies. I said that majority of the patients don't have skin rash. That's why they, clinical polymyositis. But you have to be careful. So it means that few patients have skin rash. Okay? So not all immune-mediated necrotizing myopathy patients are actually without skin rash. Some patients do. And those cases are often diagnosed with dermatomyositis by dermatologists and rheumatologists. So you have to be careful. And this is our own data. So on the figure on the left shows the demographics of the patients, anti-SRP antibody positive immune-mediated necrotizing myopathy, while the graph on the right shows those with anti-HMGCR antibodies. So as you can clearly see, there is a big peak in adult range like this. But, okay, so this is a basic, most of the cases are adults. So that's a very important point. And on muscle pathology, of course, as its name suggests, there are necrotic fibers and regenerating fibers. So, of course, necrotic myofiber necrosis and regeneration is seen. But even if you look at it very hard, no lymphocyte infiltration is seen. So this is the typical pathological presentation of immune-mediated necrotizing myopathy. So because there are no lymphocyte infiltration, this is called necrotizing myopathy. On immunohistochemistry, if you perform MHC class 1 or HLA-ABC, usually mild deposition is seen onto the myofiber membrane like this. And the membrane attack complex, so C5b9, we just learned from Tuan Vu's lecture this afternoon. This complement, the final product of the classical pathway of the complement, is deposited onto the myofiber membrane. And this is believed to be the cause of myofiber necrosis. And another recent finding reported from Berlin group, they said that there is a phenomenon called CASA, chaperone-specific associated selective autophagy, CASA. And I don't go into the detail, but it looks like this if you perform P62 immunohistochemistry. So all those findings help making a diagnosis of immune-mediated necrotizing myopathy or muscle pathology. So again, I will show this demographic data. If you look at this very carefully, in pediatric range, there are cases, not very frequent, but there is small peak, right? This is very important because many of those cases are misdiagnosed with muscular dystrophy. Okay, and this is we reported this paper in collaboration with Taiwan group and Shanghai group. And among 9 cases, around 50%, 4 of them were diagnosed with muscular dystrophy, and treatment was delayed because they thought this is muscular dystrophy. Okay, so we shouldn't just leave the patient. And this is another patient. This is our own patient reported in a separate paper. This girl had probably 8-year history of muscle disease. And at age 16, she came to our hospital and she received muscle biopsy. And look at this muscle. You can see necrotic fiber and scattered regenerating fibers. So there is active necrotic and regenerating process. But in addition to that, you see significant and marginal fibrosis. So this really looks like muscular dystrophy, right? Even on muscle pathology. And also you see fat infiltration. So finally, she came to our hospital and we made diagnosis of immune-mediated necrotizing myopathy. But even with treatment, there is almost no improvement because with this much fibrosis, there is no efficacy at all. You cannot remove fibrous tissue or adipose tissue by immune therapy. So it means that you should make a diagnosis as early as possible, and you should start treatment before patients get fibrosis. This is a very important point. So even if you think the patient may have muscular dystrophy, you shouldn't delay the diagnosis. And if you wonder, maybe we need muscle biopsy or not, in this status, you should do it. Don't delay your muscle biopsy. This is very important. And what is the mechanism? This is a very important paper. French group did a passive transfer of the patient's plasma to the mouse. So this is the plasma from anti-SRP positive patients. And this is a controlled plasma. If you inject the patient's plasma to normal mouse, they show muscle weakness. Okay, so it suggests that their anti-SRP antibodies are the cause, right? And this is, yes, this one, they also, injected patient's plasma, but after depleting IgG fraction, then there is no muscle weakness. So suggesting that IgG component of the patient's plasma is the cause of muscle weakness. Right? And this is more interesting because now you know that the membrane attack complex C5b9 is deposited onto the muscle fiber membrane, and many people believe this is the cause. So in that case, probably complement activation pathway is very important. So this is because they use C3 knockout mouse and they injected, in this case, anti-HMGCR and positive plasma, and there is no muscle weakness if they use C3 knockout mouse. But in this C3 knockout mouse, then they further added a complement artificially. Then they show muscle weakness. This is also the case for anti-SRP plasma as well. So this beautifully shows that probably anti-HMGCR or anti-SRP antibodies, they cause muscle weakness, muscle necrosis, muscle fiber necrosis, and weakness. If you understand the mechanism, now you can think about the therapy. So probably they also show that the SRP or HMGCR antigen is expressed in the myofiber membrane on the surface of the myofiber. So this is recognized by autoantibodies like this, and this autoantibody and antigen complex recruits C1q, then and following the cascade of the complement activation pathway. Then finally, C5b9 is membrane attack complex is formed onto the myofiber membrane, and this makes a hole, and that's why myofiber is necrotized. Once you understand this mechanism, then you can now invent the therapy. For example, against B cells, maybe you can use rituximab, right? And against autoantibodies, you can use plasma exchange or IVIG, or there is an experimental drug called IDES, which directly degrades autoantibodies. And also, there is an investigational drug which directly targets C1q, and there are already drugs available against C5, right? So, of course, I don't guarantee anything, but theoretically, you can think about those therapies. This is very important, right? And actually, using zilucoplan, there was a clinical trial, but yes, this one, but it didn't work. So then we don't know if maybe this hypothesis may be completely wrong, or maybe other mechanism, or other possibility is that because when we treat patients, they already have necrosis and complements are already deposited, right? After deposition, if you block complement activation pathway, maybe this is too late. So there are still many possible theories, but we don't know. But it didn't work. Okay, next one, dermatomyositis. So dermatomyositis is clinically defined as myositis with skin rash, typically heliotrope rash like this, and Gottron sign. And on muscle pathology, there are two classical, very important and diagnostic findings. One is this one, perivascular atrophy. You can see the muscle fibers at the fascicles, periphery of the fascicles, they are atrophic. That's why this is called perivascular atrophy. And this is known to be almost diagnostic of dermatomyositis. The other one is MAC deposition onto the capillaries like this. And this is also known to be almost diagnostic of dermatomyositis. So for this finding, actually many people in previous generation believe that dermatomyositis is caused by vascular problem, maybe vasculitis, something like this, without really strong evidence. But about 15 years ago, Stephen Greenberg in Boston did a fantastic job. At that time he used cDNA microarray and evaluated which genes are upregulated in dermatomyositis muscle and compared with the gene status, expression status in other myositis muscle. So here, and he found that all the upregulated genes are associated with type 1 interferon. For example, ISG15 is one of the most famous gene which is known to be upregulated by type 1 interferon. MXA as well. For both of them, red ones are, each case muscle from dermatomyositis patient. So all are upregulated. All cases, upregulated, but blue, other myositis, not upregulated at all. So after this paper, now many people started thinking that dermatomyositis is type 1 interferonopathy, right? And this MXA expression can be evaluated by immunohistochemistry. So you can see clearly all muscle fibers in this area express MXA. So now we can use this one as diagnosis, as compared with, you can see control, no expression at all. We actually compared this, we evaluated this diagnostic utility of myofiber MXA expression compared with perivascular atrophy and capillary MAC deposition. So to make a long story short, you can see the myofiber MXA expression has very high specificity, 98%. So this is practically, if you see it, you already have diagnosis. And sensitivity is the highest among those three. So this is the most useful and practical tool to make a diagnosis of dermatomyositis or muscle pathology. Look at this case. This is a 1-year-old girl 1 year, 9 months old girl who was suspected to have dermatomyositis clinically. But what we get was this one. It doesn't look abnormal at all. Actually, it looks almost really normal. I didn't choose certain place. Everywhere in the specimen was like this. So probably we would send a report back to the physician saying that, oh, this is normal muscle, if this is like 20 years ago. But look at this one, MXA, positive, right? Positive fibers, not everywhere, but clearly some fibers are positive. Now we can confidently say that this is dermatomyositis. So dermatomyositis is now recognized as type 1 interferonopathy. This concept or recognition is important not just for diagnosis, also important for therapy. I just did PubMed search, dermatomyositis plus one of those JAK inhibitors. Why JAK inhibitors? When type 1 interferon exerts its function, it first interacts with interferon receptor, and this activates Janus kinase, JAK. And this kinase actually phosphorylates transcriptional factors, STAT1 and STAT2, and once they are phosphorylated, they will make dimer like this. This dimer is the active form of transcription factor, and they go into the nucleus. Then many genes are expressed. One of those genes are ISG15 and MXA. So we still don't know the details of the mechanism, but if those genes causes the disease in muscle problem, so if that is the case, if you can block this pathway, you should be able to treat the patient. By this, based on this hypothesis, many papers tried. All of these papers actually reported the efficacy of JAK inhibitors in refractory dermatomyositis. So it means that for dermatomyositis, not just steroid, because you now understand this is type 1 interferonopathy. So you can block the type 1 interferon pathway by JAK inhibitors, right? And there are 5 specific antibodies to dermatomyositis: interferon gamma, NXP2, MI2, MDA5, and SAE. And they are all the MXA positive on muscle pathology. And I will show you the demographics as well. So all 438 cases are confirmed to have dermatomyositis by MXA expression. This is the largest cohort in the world. And you can see there's clearly double peak, right? There is a big peak in pediatric range. This is why when pediatricians talk about myositis, they always say JDM, juvenile dermatomyositis, because they have many dermatomyositis patients. But this type of graph will look different when you divide into, by positive autoantibodies. So interferon gamma looks very similar. There are big 2 peaks, but it looks when you look at NXP2, the peak in pediatric range is much higher. So clearly, NXP2 is the most important autoantibodies for pediatricians. MI2, yes, there is few cases, but only few. MDA5 also. SA, no cases, right? So the pattern is very different, suggesting that the clinical features should be different depending on positive autoantibodies. Indeed, clinical features are different. For example, interferon gamma positive cases in adults, you really have to carefully look for malignancy. And MDA5 is often associated with CADM, which is clinically amyopathic dermatomyositis. It means no muscle weakness, but skin rash. But they also have rapidly progressive interstitial lung disease, and this is also often lethal. And if you don't do anything, patients die almost like 100%. And there is another sign called palmar papule. You see, Gottron sign is usually present on the dorsal side, but in these MDA5 positive cases, you see, similar to Gottron, but you have the same phenomenon on the palmar side. MI2 cases have a lot of necrotic fibers. That's why CK is very high and muscle weakness is more obvious. NXP2 cases, as I mentioned, juvenile dermatomyositis, cine dermatitis, I will talk about it in the next slide. And calcinosis, in the chronic stage, many patients develop calcinosis. And SAE, they often show this type of diffuse erythema. Okay, so yes, what is cine dermatitis? So cine means without. So dermatomyositis without dermatitis. It means dermatomyositis without skin rash. Of course, if we talk about this, dermatologists, rheumatologists, they are unhappy because their definition of dermatomyositis is myositis plus skin rash. This is their definition. So when we talk about cine dermatitis, of course, this is totally unacceptable for them. But because now we can make a definitive diagnosis by immunohistochemistry, by MX expression. At one moment, we had 122 cases. Interestingly, 14 of them, 8%, didn't have any skin rash. And we actually sent questionnaire to the physicians and asked them to follow up for 4 more months, but no skin rash at all. So it means, yes, cine dermatitis do exist, right? So, and interestingly, among them, the majority of them have anti-NXP2 antibodies. So it means that, the skin, the percentage of muscle involvement and skin involvement may be different, case by case. But, if you have only skin rash, this is called CADM. And this is associated anti-MDA5. Now we can say that on the other side, there is cine dermatitis, which is associated with NXP2 antibodies, right? And for us, the question is whether there is any difference, by positive autoantibodies in terms of muscle pathology, because we do muscle pathology. The answer is yes, but this is too complicated, so I don't go into the detail. But there is difference. It means that there is subtype specific mechanism, although everything is type 1 interferonopathy. And I'll quickly go through antisynthesis syndrome. Antisynthesis syndrome is a myositis in which you have positive amino-acyl tRNA synthetase antibodies. The most famous one is Jo1, anti-Jo1 antibodies, which actually is the target or antigen is histidine, amino-acyl tRNA, histidyl tRNA synthetase. So depending on which amino-acyl tRNA, the antibody has different names. And there are so far 9 different types. And the newest one is LY. This was just recently, last year, reported. OJ is very tricky. Each one of them have one target, but OJ seems to recognize multiple complex. So it recognizes actually a very complex structure, not the simple protein. Okay, then this is demographics. Okay, so yes, if you are a pediatrician, there are rare cases, but it's really rare. So this is totally different from dermatomyositis, right? But in our series, of course, all cases of myositis because we do, pathological analysis. And among them, 80% have interstitial lung disease. This is usually chronic lung disease. And 67% have skin rash, typically mechanical hand. But you have to be careful because of this skin rash, those cases are usually diagnosed with dermatomyositis because their definition is myositis plus skin rash is dermatomyositis. That's why this is also called dermatomyositis. So you have to be very careful about it. And polyarthritis, fever, Raynaud phenomenon, they are usually not seen in dermatomyositis, but seen in antisynthesis syndrome. In our series, Jo1 is the most frequent, and the second most common was OJ. But you have to be careful about OJ. As I mentioned, the antigen, the epitope of OJ is very complex structure, not a simple amino acid sequence. In contrast, your commercial testing like ELISA or uroline, they just use simple amino acid sequencing onto the membrane. This cannot be recognized by OJ antibody. Okay, so it means that even if your patients have anti-OJ antibodies, almost all of the cases, then your report is negative, false negative. Never be able to detect it unless you use the original RNA immunoprecipitation method. This is, research level, laboratory, only research level laboratory can do it. And then for us, pathology is we are interested in pathology. There are two main features. One is perimyxal pathology. The other one is perivascular necrosis. This is perivascular necrosis. You can see necrotic and regenerative fibers at the periphery of the fascicles, right? And the perimyxal pathology is like this. Connective tissue in perimyxum is fragmented, and sometimes we see alkaline phosphatase activity. So, and also, the MHC class 1 is diffusely expressed, and often HLA-DR is present, expressed in the perivascular fibers. HLA-DR is rarely expressed in other myositis, except for antisynthesis syndrome and inclusion body myositis. So we also did extensive pathological analysis depending on positive or antibody, but I don't go into the details. And so, okay, so perivascular necrosis. But if you look at this one, it looks like perivascular atrophy because regenerative fibers are small in size, right? So it looks like perivascular atrophy. So one rheumatologist one day told me, yeah, this is perivascular atrophy. And this must be dermatomyositis because for them, this is dermatomyositis, right? Skin rash, with skin rash. So then how we can say this is not dermatomyositis? If you remember, MXA. Dermatomyositis is positive. Antisynthesis syndrome negative. So it means that they may look similar, but they are different diseases. Completely different. Mechanism is different, right? Finally, I don't have time for inclusion body myositis, but this is a disease of the elderly like this, okay? And the definition of the pathology is like this: endomysial toxic T cell invasion and rim vacuoles. Okay, and I'll skip this. And finally, this is the most recent concept. These invaded T cells are known to be positive in KLRG1. This is the marker of highly differentiated T cells. And as you can see, they express KLGR1. And this one, so again, the Steven Greenberg believed that this is really the cause of IBM. We don't know. We never know, but he believed it. And he actually established his own company, and the pharmaceutical company, and doing clinical trial using a monoclonal antibody against KLRG1. We don't know if it works or not. It may work. Okay, so this is my last slide. So I talked about those 4 subtypes. Importantly, DM and ASS look different, but it looks similar, but different disease, different mechanism. This is my acknowledgement. And if you do muscle biopsy or fixation, please do use our video. This is very useful. Thank you very much for your attention.